Sir, good morning, sir. Sir.
Good evening.
Yes, sir.
Are you ready with your presentation?
Yes, sir. Sure, sir.
You can start, ma.
Yes, sir.
Hmm.
Good evening, everyone. Today, my topic is on nasal intubation, that is nasotracheal intubation. It is an effective
least 15 to 30 minutes before the planned procedure, so that you get the maximum effect of vasoconstriction and mucosal shrinkage to enlarge the passage. And then another important thing you must add in this answer is the anatomy of the nose, because the medial wall and the lateral wall, they are the important structures which are liable for injury, isn't it?
Yes,
What
sir.
are the structures making up the medial wall of the nose?
Nasal septum.
Very good. Nasal septum. Or how can you classify the components of the medial wall of the nose? Any seniors? Risha, Vidya?
Sir,
Can also
Bony structures and cartilaginous structures.
bony and cartilaginous parts. Very good. So it has to be classified into bony components. Which are the bony components? Which are the cartilaginous components?
anterior is
Anterior is cartilaginous. Very good. There is a anterior cartilaginous septum. Bony is by the frontal bone and the vomerine bone. Okay. So these are the two bony structures, and these are filled with the cartilaginous septum. So this area is usually deviated to either a right side or left side in majority of the population. So first thing is you have to identify which nostril is more patent and more wider for you to pass the tube without trauma. So you must say about the preoperative evaluation after the definition, indications, a little bit of anatomy to find out the widest part of the nostril, and then the technique, whether you are going to do it under induction of anesthesia and general anesthesia, or whether you are going to do it in awake patient. Okay, and then you must go through all these steps. And supposing after anesthetizing, you said you have anesthetized patients for tonsillectomy, isn't it?
yes, sir.
So after you are given propofol and you are given the relaxant, whatever relaxant you are using, patient is now apneic. You have passed the tube. Supposing after the tube goes into say 6 centimeters, you are not able to advance the tube, what will you do? Will you force the tube, or will you have to do some maneuvers to pass the tube?
I never forced the
Try
tube, sir.
rotating the tube, sir.
Yes, very good. So you may try, because the deviation may be anterior or posterior. If it is anterior, it will be easily seen. You can see that bulge of the septum on one side, making the nostril narrower on that side, and the opposite side will be more wider. But just at the anterior side, because one nostril is wider, if you pass, sometimes there may be a bony deviation. That is why this knowledge about the medial wall of the septum and the nostril nose is important. So if there is a bony deviation, you will have obstruction posteriorly, which you cannot identify by inspection at the nostrils. So in that situation, you have to rotate the tube 90 degrees and then try to gently push the tube without exerting too much of force. And then how will you know that it has passed the nasopharynx and come into the oropharynx when you are pushing the tube or advancing the tube?
We will have a giveaway feeling.
Fantastic. That is, you will have a feel of loss of resistance. Just like you are identifying the epidural space, initially when you pass it through the nasal nares and go through the nasopharynx, you will find it is a little tight as you are pushing it. But once it has crossed the nasopharynx, because the oropharynx is such a large, roomy structure, you feel the tube has gone into a very large space and there is a sudden loss of resistance. Okay, and then you advance it, and then you try to when you do it under GA, normally after you push the tube up to the oropharynx, then you take your intubating laryngoscope, put the scope in the mouth, and then see the tube and try to advance it by further pushing the tube towards the glottic region. Okay, if it is not going directly by just mere advancing, then you make use of the Megill's forceps and try to direct it between the vocal cords. There are 2-3 problems that can happen in inserting the tube through the glottis into the trachea. What are the problems? One, supposing it goes and hitches against the so-called anterior commissure, where the vocal cords are joining together. It is like a triangular shape, isn't it? The glottic opening is like a triangular shape with both the vocal cords attached at the anterior end and wider at the bottom, isn't it? Supposing the tube goes and hitches against the anterior commissure, what will you do?
Can use a Meigle's forceps and
You have to pull the tube and then rotate, make the cuff go posteriorly. I mean, the bevel of the tube go posteriorly. Okay. So the bevel will be usually facing the left side. And in that position, it may go and hitch on the anterior commissure. Then in that situation, you have to pull the tube, rotate it another 90 degrees so that the bevel becomes facing the pharynx or the floor, and then you try to advance it, it will easily go. That is what the first problem commonly encountered. The second problem is you try to push, it goes into the esophagus instead of the glottis. Then what will you do?
Head position.
Yeah, you have to flex the head. Okay, so you lift the head at the occiput and flex the neck of the patient, withdrawing the tube from the esophagus, and then push it, then it will go. So these are the two common practical problems you will encounter while doing nasotracheal intubation. One is the tube tip going and hitching against the anterior commissure, for which you have to rotate the tube, making the bevel place the floor or the wider part of the glottic opening and push it inside. The second is the tube may be repeatedly going into the esophagus instead of the glottis. Then in that case, what you can do is you can pull back the tube into the oropharynx, lift the head and flex the neck, and then push the tube, it will enter the larynx. The third method to overcome this problem of the tube entering the esophagus is, any other technique you know of other than flexing the head and neck?
We can
Ask
use
the patient
Meigle's forceps.
Patient is under general anesthesia. You can't ask the patient to do anything here.
Can use Meigle's forceps.
Yeah, that is Meigle's forceps you are using, but still it is not going.
We can put the patient's tongue out. And
No, patient is under anesthesia, ma. You have induced the patient. Patient
We
is
can give.
unconscious.
We can manipulate the larynx externally.
You can ask
jaw
someone to give
thrust maneuver.
compression. You can ask someone to manipulate the larynx from outside. That is good. That is one technique. Another simple practical technique which you can all learn is you can partially inflate the cuff of the endotracheal tube. This will lift the tube tip towards the glottic opening. Okay. So the fourth method of overcoming the difficulty of the tube entering into the esophagus is first method is to pull it back, flex the head and neck and try to push. Second is give some external compression to bring the larynx down and then push it. The third method is you can partially inflate the cuff. Don't inflate it fully, inflate it partially, which will lift and bring the tip towards the glottis. Then you insert it to the glottis. When it is the tip has entered the vocal cord gap, then you deflate and then push further, the tube will go away. Okay, so these are all some of the practical tips you have to learn when you do a nasotracheal intubation in an anesthetized patient under general anesthesia. Then you have to talk about awake intubation, awake nasotracheal intubation, about which you talk only about blind nasal. But what is the method that commonly we follow nowadays when you want to do an awake intubation in a TM joint ankylosis patient or a Burns contracture neck? As young anesthesiologists, or do you all practice a blind nasal intubation? Or
No, sir.
uh,
We are practicing fiber optics.
fiber optic. So, Muthupriya, you have to mention about fiber optic intubation also, which is very, very important as a part of the answer. Okay. So you must know how to do a fiber optic nasotracheal intubation, both in a patient with difficulty in mouth opening or the neck position, as well as in indications where you want to do a nasotracheal intubation in a patient with a cervical fracture where you cannot position the head and neck properly, or in a patient who's waiting for a ICU ventilation where you want to do a temporary intubation with a nasotracheal tube and manage the ICU ventilation. Okay, so these are all the methods, and there are other techniques by which you can do the nasotracheal intubation apart from what I told you. So I'll just show you a small presentation on that, and that may help you to formulate your answer and make a more easy and attractive presentation for the examiner to appreciate your skills. Okay. Right. Are you able to see my slide?
Yes, sir.
Okay, right. So, nasotracheal intubation, this is the definition. Nasotracheal intubation involves passing an endotracheal tube through the nares into the nasopharynx and the trachea. Okay, that is the meaning of nasal. Even if you say just nasal intubation, it is correctly speaking, it is nasotracheal intubation. So it is short form is NTI. And performing nasotracheal intubation properly requires the knowledge of anatomy of the nasal vestibule, nasal cavity, nasopharynx, hypopharynx, and larynx. Okay, this anatomy knowledge is very, very important. So this is what is this picture showing here?
Medial.
This is the medial wall of the nose. Okay, as I told you earlier. So you have the perpendicular plate of ethmoid, you have the cartilaginous septum. What is this little area marked here?
Here is where the venous plexus merge to form little
venous
area.
plexus or vascular?
Artery.
Two vessels, superior alveolar and nasopalatine branches. Okay, these two arteries are forming a plexus called Kisselbach's plexus. All of you would have read. When you have done your EAT before here, you would have read about the superior alveolar branch and the nasopalatine branch vessels. They merge and form a plexus called Kisselbach's plexus. So this little area is the notorious area from where bleeding can easily happen. Okay, so to avoid that bleeding to happen is why we use the vasoconstrictor to shrink all these vessels. And this is the vomerine bone, and this is the nasal bone, and this is the hard palate which forms the floor of the nostril. Okay, so the nose and nostril, the floor is formed by the hard palate of the mouth. And what is this picture?
Lateral wall of the
lateral wall of the nose. Very good. So you have the turbinates, superior, inferior, middle and inferior turbinates, and you have the eustachian tube and cribriform plate and sphenoid bone containing sphenoid sinuses. These are all the structures in the lateral wall of the nose. And this third picture I am showing, just read all the markings given there, and you have
superior view of the nose.
This is a coronal section of the nose. Okay, it is not the superior well. This is a coronal section, and when you pass the tube through the nostrils into the nasopharynx and oropharynx, the tube can be passed below the structure, the inferior turbinate and the nostril sill. Some patients where this inferior turbinate is very small, the tube will be going between the inferior turbinate and the floor of the nostril or the hard palate. Whereas in patients who have a large turbinate, it may be passing between the middle and the inferior turbinate. So there are two routes by which the nostril. So when you try to insert the tube, you must look for this inferior turbinate projection. If it is small, you can put it between the middle turbinate and inferior turbinate. If it is very large, then you have to put it between the turbinate and the hard palate or the nostril sill. Then only the tube will go easily. Okay, so this is a very important practical point to avoid any injury or produce a very severe torrential bleeding that can happen from this little area by a faulty introduction of your nasal tube. Now, next thing immediately after knowing the small anatomy of this nose is the indications for what you have to do the nasotracheal intubation. Okay, the first is any intraoral or oropharyngeal surgery like tonsillectomy or any palatoplasty or any tongue resection in cancer surgery or any dental procedures. All these things require a nasal intubation, or patients who have trismus or restricted mouth opening where you cannot open the mouth and pass the tube orally, or some maxillofacial or orthodontic surgeries, or complex intraoral procedures which involve mandibular reconstruction. Now, what are the contraindications? As soon as you talk about indications, you can say which are the conditions you should not do a nasal intubation. That can be classified into absolute contraindications like suspected epiglottitis, mid-face instability, old or recent skull base fractures, known bleeding disorders. Patients with coagulopathy who are on anticoagulants, you must be quite careful. And choanal atresia, which is a congenital condition where the opening to the nasopharynx is completely occluded. But this may present as an emergency. Bilateral choanal atresia may be seen in a newborn child, where the child will not be able to breathe through the nose and it will be suffocating. So in such children, normally what is the treatment for bilateral choanal atresia in the newborn? Any idea? The child, as soon as it is born, if it is struggling to breathe and breathes with the open mouth, and the surgeon, pediatric surgeon, makes a diagnosis of bilateral choanal atresia, what is the treatment? It is a treatment similar to underdevelopment of the mandible. In a child born with a small mandible, what is the name for that condition, syndrome?
Peary-Robinson
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 sequencer.
syndrome.
So it's similar to that. Patient will be having difficulty in breathing. All you have to do is take a stitch in the tip of the tongue, pull it, and then suture it to the lower part of the mandible so that the tongue is always pulled out and the oral cavity and the posterior part of the pharynx is opened out without the tongue falling back and causing an obstruction. Okay, that is a emergency treatment that you have to do for choanal atresia or children born with Peary-Robinson syndrome. Okay, so these are the contraindications. The relative contraindications are any large polyp or foreign body, as he rightly said, obstructing the nasal airway, or any recent nasal surgery, or history of frequent epistaxis. A patient who says he had been bleeding through the nose recurrently, better to avoid nasal intubation in such case. Next thing is, what are the equipments you need to do a nasal intubation? Contrary to your oral intubation, where you require only a laryngoscope and the tube, if at all, sometimes you may need a stylet to position the tube or the bougie in case of difficult intubation. The equipment needed for nasal intubation are, you have to mention what are all the types of tubes that are available. I think Muthupriya did not mention anything about the nasal ray or the standard endotracheal tube or the armored tube which sometimes we use. So these endotracheal tube of special make like nasal ray, standard endotracheal tube, or sometimes you will be using a flexometallic tube also in cases of extensive oral cancer surgeries. We prefer to use a flexometallic tube which can be bent towards the forehead and away from the surgical field. And you require a lidocaine jelly or a water soluble lubricant to nicely lubricate the tube. You require a Magill's forceps. Why it is called Magill's forceps?
Bagels discovered the forceps.
Who is Magill?
Um,
Now the short note question in your theory paper, sometimes in the history of anesthesia, they may ask you about this. He is a very, very important person.
Yes,
His
sir.
full name is Sir Ivan, I-V-A-N, Ivan Magill. Okay. And he was the man who designed the initial endotracheal tube, Magill's tube. Nowadays you are all used to only the disposable plastic or PVC endotracheal tubes. But during our PG days and earlier, it was the red rubber tube which is reusable, which can be autoclaved or even boiled in the sterilizer, and we used to reuse it. It was made up of red rubber tube. That red rubber tube was designed by Sir Ivan Magill, who was an anesthetist to a very famous plastic surgeon called Harold Gillis. These two people, the plastic surgeon Harold Gillis and the anesthetist Ivan Magill, did a lot of facial trauma and facial surgeries in the soldiers who got injured in the Second World War. Okay, so Magill designed so many things. He was the first person to achieve endotracheal intubation with this sort of curved tube, both in awake as well as asleep patients. And he was the person who designed this forceps to direct the tube into the trachea. Okay, so he was given that honor of Sir. Yes, Sir is not part of his name. It is the title given by the British government. So Sir Ivan Magill is the person who contributed a lot, and he was the one who popularized blind awake intubation also. In cases where they could not induce or make the patient unconscious, he was the person who successfully did more than 2000 awake blind intubation under topical analgesia. Okay, so these are all the credits which Sir Ivan Magill has. And this Magill forceps, as Muthupriya rightly said, it has an angulation to prevent you from or getting the obstruction of the tip. So any instrument which has an angulated holder for your fingers will always give you a clear vision of the tip where the vision is going. So a similar forces will be used by the ENT surgeons for packing the nose before doing the so-called nasal septum correction. In earlier days, it was called SMR, submucosal resection of the septum. So they use the angulated bayonet forceps, which also will have a angulation to hold the tip and the instrument with the tip clearly visible. So this is an instrument. Then you require an intubating laryngoscope if you are going to do it under GA, and you have to use this vasoconstricting spray, as she rightly said, and you require a syringe to inflate the cuff as soon as the tube enters the larynx. Now, how are you going to prepare a patient for nasotracheal intubation? This is the next heading under which you should say. And that depends on whether you are going to do a awake intubation or a asleep nasotracheal intubation. Okay. So first we have to pre-anesthetic evaluation is very, very important. And this should be done to assess through which nostril you are going to pass the tube. Okay. So you ask all this history, any history of coagulopathy or recurrent epistaxis, any previous nasal surgery or trauma, and look for any deviated nasal septum, which is common in the anatomical anomaly affecting the anterior cartilaginous part or rarely the posterior bony part. And that is the reason why I told you must have the knowledge about the medial wall of the nose. Then choanal atresia is very uncommon, but present symptoms of nasal obstruction in childhood itself. And if you are planning for awake intubation, you must do the counseling. You must talk to the patient and tell them how you are going to do and why you are planning to do it when the patient is awake. And you must tell what are all the things that the patient is likely to feel. It may not be a pain, but it will be a pressure, and he has to bear with that, and he has to cooperate by breathing come deeply without holding breath, and all these instructions should be properly given to the patient. Then first step in performing is to general application of the vasoconstrictor spray bilaterally. Even for general anesthesia, you have to do this so that you will avoid any bleeding. Then options include, these are the drugs which you can use, and you can use sometimes cocaine also. Cocaine was a drug which was used in the earlier days. What are the advantages of using 4% cocaine? Sometimes in your practical exams, this may be asked. What are the advantages of using cocaine for nasal intubation compared to lignocaine? Cocaine, what is cocaine actually?
The vasoconstrictors.
Ester anesthetic, local anesthetic.
That was the first local anesthetic to be discovered. And who discovered it and popularized it? All history, storytelling. Who is Carl Kroller? Have you heard of the name Carl Kroller? C-A-R-L, Carl Kroller, K-R-O-L-L-E-R. Carl Kroller was actually a Viennese ophthalmologist. Okay, and he was working under Sigmund Freud, who was a psychiatrist, and both of them were doing experiment on a leaf called Erythroxylum coca, or the coca plant leaves, which the native people used to chew while they were climbing the mountains, and that used to give them a little bit of euphoria and prevent the tiredness that they feel while going uphill. And so Sigmund Freud was doing some research with the coca leaves to find out what makes the native people get little inebriated or feel little booked up because chewing these leaves, and he found that contains a chemical called cocaine, and he was preparing a paper to submit the effects of this coca leaves extract cocaine, and he went for a conference. At the time, Carl Kroller was being an ophthalmologist, he was chewing the coca leaves, and his saliva fell into the eye of the patient. And the patient had complete numbness of the conjunctiva, and he was able to do the eye examination without any difficulty. So he started using it for all his eye surgeries and popularized it as a local anesthetic. So cocaine is a ester local anesthetic, which not only has the local anesthetic potency, but also it's a powerful vasoconstrictor. So it is a 2-in-1. When you use cocaine, you need not apply the vasoconstrictor separately. And there can be a short note question in some of your theoretical papers called Moffat's solution. Have you, anyone of you heard about this name? M-O-F-F-E-T, Moffat's solution.
No, sir.
Are you aware of this name?
No, sir.
Try to find out the answer. Let it be a homework question. So these are the things that you first do. Then nasotracheal intubation under GA. What you do free oxygenation as you do for any other patient. Then induction agent given by muscle relaxant. Lubricate the distal end of the nasotracheal tube before inserting it into the selected nostril. And immersing the tube in warm water helps to soften the tube and prevent injury and bleeding. So I always practice this, especially with the new disposable tubes, which are made up sometimes of very hard plastic. I routinely immerse the tube in warm water for a few minutes before I start the intubation, and that will make the tube quite supple, and you can insert it easily without much trauma. And when the ET tube has reached the posterior nasopharynx and passed to the subpalate in the oropharynx, you can do a transoral direct laryngoscopy is performed, and Megel forceps can be used to advance the tube between the vocal cords into the trachea and the direct vision. So this is under GA. So you pre-oxygenate, you induce, you paralyze the patient, you insert the tube, everything without the laryngoscopy, And once the tube has gone into the oropharynx, as I told you earlier, by the feel of sudden loss of resistance, then you put your laryngoscope, visualize the tube lying in the oropharynx, then advance it either with the right hand into the trachea, or you can use the Meggle's forceps and direct it into the vocal cords and trachea. This is the way we do it under GA. We don't use any local anesthetic spray here normally. Okay. So what are the difficulties you can encounter during this procedure of nasotracheal intubation? Some manipulation may be required while passing the tube through the nasal cavity, as you may sometimes feel some resistance. And if the amount of resistance felt is significant, what you have to do is you have to reposition, rotate the tube as correctly told by Mutya earlier, or you can try for the other nostril, or you can go for a smaller size CT tube if needed. Don't ever force the tube with too much of power, so that you will otherwise you may be causing a lot of bleeding and damage. And for nasal ray tube, the diameter of the tube is proportional to its length. So when you say for a adult male, you have chosen a 8.5 ray tube, and it is not going through the nostril and into the trachea, I mean the oropharynx, and you switch over to an 8 size tube, the 8 size tube length will be slightly shorter than the 8.5 tube. So you have to be quite careful when you choose a smaller size, and you have to make sure that the cuff is pushed well beyond the vocal cords, so that when you move the head, the tube should not come out. Normally, when you extend the neck and head for surgery, the tube usually slips out or comes out of the trachea. So you have to be very watchful in this. Then the position of patient head should be noted during and after intubation, so that you know at what depth it is gone in correctly. Okay? And the extension of the neck can force the balloon. So if you have put in a smaller size or the little shorter length tube, then what will happen when you extend the head and neck? The inflated balloon will come and hitch against the vocal cords, and slowly the vocal cords will swell up, and when you deflate and remove it at the end, you will have a severe laryngospasm, or it may lead to injury. And sometimes part of the balloon may come out between the vocal cords into the oropharynx, or sometimes the whole tube itself may come out as a extubation. So you have to mark the length of the tube, especially when you do oral cancer surgeries. What I do is, after I confirm the placement correctly, I take a marker pen and mark it in the tube itself before fixing the tube. I'd say it is 26 centimeters, 27 or 27.5, whatever be the length. You make a mark with the marker tube, so that you will know whether the tube is migrating inward or coming out. So it should be at the correctly at the nostril level. So this is an important point whenever the surgical manipulation requires movement of the head and neck. Now, next thing is complications. You can mention about what the complication. Most common complication is bleeding, epistaxis. This is a very, very common, right from the entry point to anywhere in the lower down, it can cause bleeding. Other complications are bacteremia. That is, if the tube is can carry the bacteria from the nasal cavity into the blood and cause a bloodstream infection, or perforation. Can perforate the pharyngeal soft palate or the pyriform fossa. So these are the things after you have to say about intubation under general anesthesia. Now coming to the technique of nasal intubation. What are the things that you have to do is, the patient is premedicated with a small dose of midazolam and a drying agent like lacoperlate. Nasopharyngeal topical anesthesia with 4% xylacine is done with a spray or a nebulizer. Okay, so when you want to do an awake blind nasal intubation, these are all the steps that you have to follow. Then you can do translaryngeal anesthesia with 2 cc of 2% lignocaine which you spit into the trachea by puncturing the cricothyroid membrane. Then the new tube is inserted into the selected nostril, which you have examined and found out earlier, and advanced inferiorly and posteriorly following the floor of the nose that is formed by the heart palate. Then you keep listening to the breath sounds, and when the tube is in the pharynx, the patient is instructed to breathe deeply. So you must try to breathe as harsh as possible. And if the tube is in the midline, it enters the larynx below an immobile epiglottis between the areflexic vocal cords. Now, how do you confirm the ET tube position after blind intubation? This is a common question they may ask you in the examination, practical examination, that when you do a blind intubation, first the question they may ask you, have you ever done a blind intubation? And if you say yes or no, whatever it is, you have to know, have a knowledge about blindness and tracheal intubation. So what are the confirmation points to say that the tube has entered the trachea? What is the first and foremost thing that will happen?
Bilateral chest raise and ETCO2.
ETCO2.
That is objective.
Fogging of the ET tube.
Clogging, it is the smogging, that is the expired air will have some water vapor, so there will be some smogging in the tube. But first and foremost is patient cannot phone it because the patient is now conscious. So if you ask him to say his name or ask him to talk something, he will not be able to talk. Okay, so in your pre-anesthetic assessment itself, when you plan for a blindness intubation, you have to tell the patient that if the tube I am passing is going into the right passage into your breathing tube, then until I remove it, you will not be able to talk. This is a very important instruction that you have to give, because I had a bitter experience of intubating an IAS officer without telling this, and I succeeded in my first attempt in passing the tube into his trachea. And immediately he became agitated and he started showing signs that he wants to write something. So we gave him a paper and a pen, and immediately he wrote, "I cannot speak." Then only I realized that I should have told him that he will not be able to speak. So I have to explain it to him, saying that because the tube is there, he won't be able to speak. And as soon as I remove it, he will be able to speak. I have to convince him with great difficulty, and he agreed. And then we proceeded with the surgery. So from that day onwards, I always tell my patients, because we are doing it in the awake position, awake state, patient will be little frightened or agitated. They try to speak and they cannot speak. That will give them a lot of scare. Okay. Then capnographic waveforms. Then you can connect it to the breathing circuit and see the reservoir bag movements. Okay, these are three important confirmatory points to know that the tube has gone into the right position. And there are some techniques which are described for nasal intubation. The first method is to use the Nagel's forceps and guide it into the trachea under vision. When you do it under GA, it was done by Nagel in 1920. And there are various aids for blind nasal intubation also. One is listening to the breath sound through the ET tube or using that small equipment which she described, which will give us a whistling sound. You can attach it to the distal end of the tube, and through the patient's expiratory air, it will give a whistling sound. And you can inflate the tracheal cuff slightly and try to bend the tip towards the trachea and glottic and push it. Or you can use the end-tidal carbon dioxide can be connected to the distal end, and you can gradually advance the tube, and once it goes into the trachea properly, you will get a complete waveform. Normal capnographic waveforms will come. And with the tip in the pyriform fossa, supposing it goes into towards the right or left of the vocal cords, then there is a small recess called pyriform fossa, and that where you can see a bulge in the skin, because the tube will come and push that pyriform fossa, you can observe a small bulge in the skin, and then you can withdraw the tube and redirect it into the rotate it 90 degrees and advance to the midline. Then, depending upon the curvature, a minor adjustment is required at the atlanto-occipital joint extension, that is flexing the neck. Sometimes tube may be abutting the anterior commissure. In that condition, you have to flex the head and pass the tube. If the tube enters esophagus, withdrawing the tube and reinserting with the head in hyperextended state achieves intubation. Then stylet facilitated. You can pass a stylet and bend the tip of the tube. Always the beveled tip should be little upward angulated so that it can enter the glottic easily, and that way it will help to insert the tube into the glottic opening recently. And there are instruments called a light wand, which will have a light at the tip, which can be used as a stylet, and we can see the light. You can switch off all the lights in the amphitheater, and we can see the light gleaming through the skin, and using that you can advance it. Once it goes into the esophagus, you will not see the light. But if it enters the trachea, because it is the structure immediately below the skin, you will see the light glowing there. And there is a special tube called endotrol, ET tube, and that can be used along with the right advance. I will show you a picture of endotrol later. I have got it in one of the ASCIIs, where it has got a ring. If you pull that, the tip will bend and it can easily enter into the trachea. Then there is a fiber optic nasal intubation. So this is also important thing that you have to remember. So without mentioning fiber optic, your answer will not be complete. So this is the most important gold standard for nasal intubation nowadays in difficult intubations like TM joint ankylosis, Burns contracture, and other conditions. So you must mention about the fiber optic nasal intubation also. So if you
Okay, sir.
classify under the subheadings, I think your answer will be complete, and you will be giving a much better presentation. And otherwise, I think Supriya has done a fairly good job by mentioning all the points. Only thing you have to reclassify under the subheadings and alter your presentation. Okay?
Okay, sir. Thank you, sir.
Good. Very good. Very good.